This
Like I have one,
conference will now be recorded.
and I have one I think you'll like a lot. Let me bring it up here. We'll start with this one first and share my screen. All right, so you should see a radiograph. This is just a good medical student case, but a nice one that you can glean some anatomy without having the CT scan. So we can see this patient had a pacemaker placed and the generator's in the left wall, chest wall, and the course of the intracardiac leads, of course, is not our typical course into the right superior vena cava, but rather come down here. Now, these aren't arterial. It's too lateral to be in the aorta. And also, this is not where they would put it. If we go to the lateral view, you can see they are indeed in the right locations. Patient had a previous generator, and there's an abandoned lead in there. They connected a third one, so I'm not sure why there's two in the right ventricle like that. There's the right atrial lead. But as you can imagine, this is a left SVC, and following the rule of congenital things, there's also an azygous fissure there, so not uncommon to see two congenital things. And I have a CT done before the pacemaker that just shows the anatomy. And this is kind of a cool one because you'll see there is a tiny thread-like bridging vein between the left and right SVC, but no one's going to get a wire across that one to place a pacemaker. So this patient, unless they go in on a right, they're never going to get a right approach. But this is a healthy, large vessel, so there's no reason they can't put the pacemaker in there. Some patients won't have a right SVC at all, so they have to go in on the left. So this is when this variant anatomy can become important. What else is kind of cool is you can see contrast in the valves in the azygous vein, which in the early days of CT was sometimes mistaken as calcification, but hanging out here in the fissure, it's even easier to see. So left SVC with pacemaker, pretty straightforward. This next case is another anatomy case. So this patient was intubated, and you can see the gastric tubes all coiled up here in the neck, in the upper the pharynx. But the interesting thing is this left IJ line here. You see it comes down, and then it foreshortens here. It changes direction. It's either coming towards or away from us, and then it loops down here immediately, and it looks like it could be in the aorta, but this little turn in it's a little odd for something arterial. It should come straight down. This was put in the IJ vein via ultrasound. Now you could go through and miss and get in the carotid. That absolutely can happen, but then we have to think about where other places this could go. So it's not following the course of a left SVC. It could be going into the internal thoracic vein that can course immediately along the sternum. That would be one possibility, but it's pretty hard to get it in there. And the other possibility is it's going backwards into the superior intercostal vein, which can be large in some patients. So this patient has a CT scan that shows where this vessel is. So there's the IJ coming down the axillary, the subclavian vein joins it, and there we can see there is no the brachiocephalic vein again is absent or occluded, and there's a lot of retrograde flow in this vessel here, which is a superior intercostal vein going down into the accessory hemiazygous. There's the interazygous vein, comes back up the azygous vein and drops in on that side there because there really is no bridging vein. So this is a central line in a large superior intercostal vein. So this little turn in there tells you it's probably not arterial. Of course, you can just put a transducer on. They left this in for a couple of days, but then finally removed it. It's a very small caliber catheter. And that's one I had not seen before in that location. This last patient is the most interesting case. So this is the 69-year-old guy. He didn't have any history other than he had an abnormal radiograph that showed what they thought was a large bulla. So here's his CT scan, and you can see there's already a difference in lung attenuation, and we see some rotation of the mediastinum towards the right. So out here we have low attenuation. Vessels are very small or not visible. We don't see a lot of airways. As we come down, there's some normal parenchyma anteriorly in the right upper lobe. There's some bronchial wall thickening in the right upper lobe. There's a normal right upper lobe airway there. There's the apical segment, anterior, posterior segments. Then we come down and we can see there's more of the right lung. There's a lot of bronchiectasis posteriorly. there, but there's a lot of this hyperlucency, and there's a little bit on the left. There's some subtle areas of decreased attenuation, but overall the left lung is mostly normal. There is some air trapping or at least hyperlucency and a little bit of bronchiectasis in there, in the lingula in particular, in the medial and posterior left lower lobe. So I don't have the radiograph, unfortunately. I wish I did, but David, I hope you'll agree, but I think this is a nice example of Swyer-James-MacLeod syndrome. And it's not unilateral, as it mistakenly is declared to be. It's an asymmetric process. It's just one is usually more apparent on a radiograph as being lucent. This case predominantly involving the right lung, presumably some infection, particularly down here a long time ago, causing that abnormality. And here's the coronal, just showing the differences.
Very cool, Jeff. So it's interesting that people with bronchiectasis have about a 50% chance of having some constrictive bronchiolitis too. In this case, the constrictive bronchiolitis is way ahead of the bronchiectasis, but there was undoubtedly some airways infection. And the fact that the right lung is fully developed, it has normal size. As a matter of fact, sometimes it's puffed up to greater than normal size, means that this infection probably occurred when the person had achieved most of adult size, because that right lung is not smaller than it should be. So I'll bet you he was like 10 or 12 years old or something like that when he had this had an infection.
Right. And if we look at the soft tissues as well, you can see there is a pulmonary artery there. The pulmonary veins are small, and there's some smoke. This right inferior vein, I think it's there, but I think it's just there's hardly any functioning lobe down there, so it's just probably very small. And then there's.
But if this happened early in life or was something congenital, then that right pulmonary artery wouldn't be at this normal size.
Right. Correct. So
very cool.
Yeah. So I think it was one of the better examples I've ever seen of what we call Swyer-James-MacLeod syndrome. But the important point is it's taught as a unilateral hyperlucent lung, but that's the radiographic appearance because of the asymmetry, not because the disease or the condition affects one lung. But all the cases, I know you've shown several, they're asymmetric, and that can distinguish it from like alpha-1 antitrypsin deficiency or like a full-blown constrictive bronchiolitis from, say, an inhalational injury. Like some of the popcorn worker lungs, or constrictive bronchiolitis from something that affects both lungs equally.
Got it. So the original article by Swyer and James was called Unilateral Hyperlucent Lung or something like that. And so that stuck. Unfortunately, the case that they had that, generated the case report, this was in the pre-CT days, it was strikingly unilateral. That's probably what drew their attention to it, and then they published it that way. So people thought, well, Swyer-James has to be unilateral, but it was just that lucky first case of constrictive bronchiolitis from infection happened to be unilateral, and that is probably why it got published.
Yeah. It still shows up in the books as that, unfortunately.
Right, and as a matter of fact, I've had discussions with pulmonologists in the last couple of years where they said, well, this can't be Swyer-James because it's not unilateral. So, I banged my forehead with my palm on that one.
We'll have to add that to our myths and misconceptions list.
I think that's a good idea. I hope you're keeping a list.
Oh yeah, Howard had a nice shared folder with all the ideas. I'll add it onto it. All right, I'll make you the presenter now.
Can you see a CT scan?
Yes.
Okay, so this first person has lots of lymphadenopathy, and the lymphadenopathy is most extensive here and most dramatic with these inguinal nodes here. But everywhere you look throughout the abdomen, there are all these little blobs of lymphadenopathy. So it's really very widely disseminated lymphadenopathy. And so the person really came in, I think, because of some GI symptoms and stuff like that. And there's another element of history here which we can we can go into a little bit, and that is that this person has had tricuspid atresia and has had a number of operations on the tricuspid valve. And I'm going to show you I'm going to go to the chest CT, which I think I have nearby here, I hope. Let's see, chest, here we go. So on the chest, you can see that there's a lot of contrast regurgitating from the cava here into the azygos vein, which is very dilated, huge back here. And then eventually, some of this contrast in veins makes its way across the mediastinum. We see this contrast in intercostal veins back here. And then there's a big knot of vessels down here, which ultimately dumps into the left inferior pulmonary vein. So we have communication here of systemic veins communicating with this inferior pulmonary vein on the left. So we've got all this venous collateralization here. You can also see the collaterals here under the skin, and that's all because of this obstruction on the right side from multiple complications of tricuspid atresia, several operations and valve failures and so forth. So that's another finding. But the lymphadenopathy was the big thing here, and I think there's also some axillary lymphadenopathy in this person. And so the consideration on this set of CT scans was that this person probably had lymphoma. And it turns out that this person has Kaposi sarcoma. And as part of the workup here, HIV was identified and HHV8 induced Kaposi sarcoma was diagnosed. So this was not lymphoma, this was KS. We don't really have the traditional lung findings of KS, which can be nodules or sometimes flame-shaped nodules associated with hilar structures and radiating out into the lung. So we don't really have that finding. We don't have that much hilar lymphadenopathy at all, but this was KS. It was identified on a rectal biopsy. Man did not have skin lesions of KS either. So HHV8 associated Kaposi sarcoma in the setting of HIV/AIDS. Okay, so this next case is somebody with a big pleural effusion. I've shown this, I think, to Howard and to Travis in a small session we had over the Christmas holidays where nobody else attended. So some other people might have seen this case if they happen to have logged on at that time. This person has a large right pleural effusion. You can see a drain in place. And if we look at a CT scan in that era, we'll see that there is indeed pleural effusion, and there has been a very large, at times, pericardial effusion as well. Probably a little bit of ascites as well. So this is a related condition. This is primary effusion lymphoma, which is a kind of diffuse large B-cell lymphoma. It's pretty aggressive. And this is traditionally associated with AIDS and HHV8 again. So this is another one of the HHV8 induced malignancies. And it presents with effusions in cavities such as pleura, peritoneum, and pericardium, and rarely even in joints. So joint effusions can be involved with this kind of lymphoma. There's usually not a lot of lymphadenopathy in this person. I don't think this person has very impressive lymphadenopathy, just a few nodes scattered around, but nothing really that juicy. And the thing that's even rarer in this case is that this is not HHV8 or AIDS related. So this turns out to be EBV related primary effusion lymphoma. So I thought this was going to pair up with my other case of being both manifestations of HHV8, human herpes virus 8 infection in the setting of HIV, and it turns out this person doesn't have HIV, AIDS, or HHV8, but instead has EBV as the driver of this primary effusion lymphoma. So the manifestations are mostly effusion and not much in the way of lymphadenopathy. I've only seen one other case of this, And that person had scattered small nodes, sort of like these little nodes that we're seeing in the axilla here, but nothing really that impressive. And didn't have that much in the way of effusion, but still had the diagnosis, I think, had effusions now and then. So primary effusion lymphoma, kind of diffuse large B-cell lymphoma, usually associated with HHV8 in the setting
So,
of AIDS.
David, are the lymphoma cells just floating around in the effusions? Because there's not, I mean,
That's right.
I've seen some pleural lymphomas where it's more of a
Right,
mass that's sort of,
nodules, yeah. Yeah,
hmm.
you usually don't see masses in this case, in this thing. Okay, so I thought I was going to have a pair of HHV8 cases, but this one is EBV, so I could have just faked it, but I decided to be honest and come right out
We
with
get it. Still has an abbreviated name. There you go.
it. Okay, so this person has low lung volume, has an exaggerated eventration of the right hemidiaphragm, and has abdominal obesity, and then has, so this person is having to breathe against all of this, and you can see that it's taken a toll on the diaphragm, and this person has this impressive hypertrophy of the diaphragm. So we have this diaphragm muscle hypertrophy here. We can see it in the posterior aspects of the muscle, and then we also see it in the anterior muscle here. So this is really thick anterior muscle here. So the person also at this point was an alcoholic and has fatty liver because of alcohol. So this is really obesity related extra work on the diaphragm, and the diaphragm, this is a fairly young guy, I think around 30 years old at this point. The diaphragm will respond like other skeletal muscle to increased load and will bulk up. So this is expected diaphragm hypertrophy in the setting of abdominal obesity, this person. So people talk about atrophy of the diaphragm and paralysis and stuff like that. We've seen several cases of hypertrophy and some abdominal mass like obesity, or I've seen it with polycystic kidney disease or hepatosplenomegaly or ascites. These things will also induce hypertrophy. And then because of the increased abdominal pressure, eventration, which is just slow expansion of an unsupported part of the right, usually the right hemidiaphragm, stretching, progressive stretching of that also goes with abdominal obesity. It also goes with ascites. So the things that induce hypertrophy can also induce or promote expansion of eventration. This guy's got both. Okay. This person had a bad sore throat and then had shortness of breath and has this set of radiographs. There are bilateral pleural effusions here, and perhaps you can see some ill-defined nodules, not so impressive. But if we look on CT, then we see there are a number of smudgy, mostly peripheral nodules here. And in the setting of pharyngitis and all, this would fit with Lemierre syndrome, meaning a septic thrombosis of veins in the back of the throat. There is accompanying pleural effusion here, probably because some of the infection has gotten into the pleural space. And this grew the typical organism, which was Necrophorum. So this is the classic organism. And at the top of the CT scan, there was a hint of thrombosis. You see, I think there may be thrombosis here in this vessel up here, but it's really right at the top of the imaging, and it's not for sure. So maybe we were seeing it here. There was a few days later a dedicated neck CT, and it did not show any thrombosis of neck veins, but they might have cleared by that time. So I think it's, it's suggestive, but it's not definite based on the limited venography we have here from the CT scan. So this was Lemierre syndrome. It had the right organism and it had the right clinical setting, and this person, I think, cleared up with antibiotic.
A lot of lung involvement there.
Okay, this person has this widespread abnormality throughout, so we've got some extra little bit of extra tissue here in the mediastinum. We've got stuff around the aorta. We've got it in the posterior paraesophageal region here. It goes down into surrounding the aorta down here. And then just a ton of retroperitoneal stuff here surrounds kidneys. And it's just this huge amount here of stuff. So you think about lymphoma, and this was Erdheim-Chester disease. So this is this histiocytic collection here, and the shaggy kidneys is one of the hallmarks of that, or it's called actually hairy kidneys. So this is more than hairy kidneys because we've got all of this more central retroperitoneal component too. And the periaortic shadows, I've seen in a number of cases, including the first case that where I learned about this disease here. It was thought to be giant cell arteritis because it just formed a cuff around the aorta. This is more extensive than just a cuff, but it's the same distribution. So Erdheim-Chester disease, I don't have a chest radiograph, surprisingly, to show you along with this. Okay.
Were any? That was a nice one. Were there any bone things?
Yes. Yeah, I didn't show you, but there was indeed long bone sclerosis in this person. I need to get those. There's a little bit of a hint of it here, I think. We're seeing
maybe there.
And even in the maybe even in the arms, in the humeri here. Yeah, that's a good point. So I need to collect those bone films. So that everybody thinks that that's extremely common in Erdheim-Chester. And the reason that they think it is because the biggest series until about 20 years ago, the biggest series of Erdheim-Chester cases all came from a bone clinic in France. And so they reported their stuff, and everybody had bone sclerosis, symmetrical long bone sclerosis. And so people say, well, that goes with Erdheim-Chester, and you've got to have that to have Erdheim-Chester. Like 79% of their people had it, or some large number. But that was all selection bias because it was a bone clinic.
That's great.
Okay, this person has a sarcoma. I think it was a sarcoma of the right lung, and this is after some surgery, and I don't know whether there's also radiation at this point. But the left lung, we've got some scar up here, but the left lung base is not that impressive. But with time, let me see if I can show you. There were lots of left lung nodules that showed up. So lots of metastases here to the left lung, including this lesion down here. So we got this more central lesion. This is tumor. And this grew. It's, and got to be quite large like this. And then, so this tumor nodule grew, and then now we have developed a pseudoaneurysm of the left pulmonary artery. Are you seeing both screens, Jeff?
Yes.
Okay. So we have this large pseudoaneurysm here caused by basically tumor destroying the wall of this pulmonary artery. So we went from this nodule here to a larger nodule, and then eventually to this pseudoaneurysm formation. So pseudoaneurysm resulting from tumor erosion of the vascular wall. Not a happy finding. And
well, that's impressive.
Yeah,
I haven't seen too many pseudoaneurysms. I mean, occasionally you get like a ruptured, if something cavitates or something, but just tumor causing pseudoaneurysm is usually more obstructive. I don't think I've seen that many of those.
Well,
especially that big.
I don't think I've seen any. So, so welcome to the club of naivete. Okay, right. So this person had remote TB. This is man, I think in his 60s or 70s, and has this extensive pleural calcification, blending of the costophrenic angle. And if we look at it on CT, again, we see the pleural calcification, and then we see this thickened fat layer underneath it. So we have a lot of thickening here. Part of the thickening is calcified, but a lot of the thickening is not calcified. And because there's all this tension then on the parietal pleura, it's being sucked immediately by this shell, and where the fat around it has sort of expanded to fill that space here. So we have this thickening of the fat layer, and the fat is not quite pristine. It's got some, probably a little bit of scarring in it. So there might be an inflammatory component that's causing some scarring within the fat. It's not as clear, for instance, as the subcutaneous fat is out here. So it may be partly scarred, but very nice hypertrophy of that fat layer there, mostly I think caused by just tethering and inward pulling of this calcified parietal and visceral pleura, which are welded together. So particularly where the angles are more acute, you're going to see a wider version of this. So most of this stripe that we're seeing is actually this hypertrophied fat layer outside the thing. And then we have the pulmonary finding that goes with pleural thickening, which is round atelectasis. So the lung is contracted over the surface here. It sort of pulls the lung together. And if you saw vessels, you can sometimes see that comet tail curving in here, representing again the contraction of the outer layer of this whole thing, this round atelectasis. And
you also have some
tumor.
Go ahead, David.
It's good to give contrast because usually with round atelectasis, you see pretty homogeneous opacification, the way you would expect with atelectasis. Whereas with tumor or infection, it's going to be inhomogeneous in most cases. So nice homogeneous opacification is good for round atelectasis versus bad things like tumor or infection. What were we going to say, Jeff?
I was going to say you have another nice finding of chronicity of inflammation. It's subtle on some images, but you have hypertrophy of the inner cortex of those ribs, hyperostosis, I mean. They just look a little thicker than the contralateral side.
Look at this in particular down here.
Mm-hmm. And that's a great finding for chronicity of a pleural process.
Got it. So it's probably a hyperemia or something like that that stimulated that. Okay, those are the cases. Thank you.
Wow, great ones. Thank you so much. All right, well, we'll just end early today and meet again next week. David, if you want to stay on, I can chat to you about that NIOSH letter.
Okay,